So now we have our open moderated discussion that will be coordinated by Cynthia. So I invite the speakers to put on their camera. We got some more questions for you. And the participants that want can still ask questions in the chat or raise their hands. So Cynthia, go ahead.
Yes, don't hesitate to ask your questions in the chat or raise your hand if you have some questions. At least, thanks a lot for your interesting speeches. And so I have some more questions. I will start with Anna from Wales. What would be your recommendations to other regions facing the same problems?
In terms of what? In addressing the health?
Yeah, in your
personalised healthcare?
Yeah.
Yeah, I think what we found in today, and my feedback from today's discussion, is how similar the issues are facing all countries. So I think my first recommendation would be, and something that we try and do, is before you try and reinvent the wheel, to look at good practices that are happening elsewhere and see if you can benefit from lessons already learned. I think all the speakers today have more or less highlighted the same issues in terms of recruitment, retention, elderly populations, the demographics, access to healthcare, the use of digital. It's very similar, and working in partnership as well is a big thing to commend, because not only can we learn from each other, the people who live in rural areas can benefit as well from the interventions maybe that are being implemented in other countries that could be maybe modified to suit your own economic, social, and cultural structures, but there are definite benefits to be gained from working collaboratively with others and learning from other best practice. Digital health, definitely the way to go forward, but not to lose the personal thing. And I think, we talked about education and training and the need to have opportunities to do that in localized areas. I think somebody mentioned, and something we found, that if you were born and grew up in a rural area, you're more likely to be working there. But you need to be able to train there as well, because doctors, nurses who train, and whichever region they train in, do tend to then stay on and become professionals operating in that area. So we found the carer and longitudinal clerkship models to be excellent, and those are models that we took on board after looking in Australia and New Zealand and their experiences, so it all comes back full circle.
I have a question for the other Anna now, because I've seen that all the regions or countries you are working on have first made a strategy for telehealth, I think, or something like that. So it's maybe the first step, and then you can go to the operational plans of it.
That is correct. That in all the countries that we study, we find this e-health governance strategies, and of course that is a support to those working with digital solutions in healthcare. But there is often there is a very long distance between a strategy and what is actually going on in practice. So there are a number of steps, a number of measures to be taken to make sure that what is put in the strategy is actually implemented. And again, one of our results was that the importance of involving the healthcare staff in the implementation of those new innovations and technologies.
Yeah, and maybe according to you, what would be these different steps then from the strategy to the real implementation? Then is it the obstacles you were mentioning?
Actually, there is a good example from Norway, where they have been working with the implementation of digital solutions in the social care sector. And they have actually taken out a model of different steps, how you can go about to implement those solutions. And they offered all the municipalities and regions in Norway to be part of this program, and to involve in a collaborative work of implementing digital solutions together, to also to reap the benefits of learning from each other and learning from best practice that Anna just mentioned. So that was done collaboratively, and they selected a number of digital solutions that were then implemented in a large number of municipalities. And after having implemented those first solutions, they could move on with the next set of digital solutions. So different ways of facilitating the implementation, but I mean, this is not rocket science, I would say. It's always difficult to implement new solutions, whether it is digital solutions or other new ways of doing things. I think the processes that you have to engage in are very much the same, and the importance is to take this seriously. And I think it was interesting to hear about all the good examples you have from Wales.
Yeah, you have the change management and all the aspects also to work on. Do you have? I had also a specific question. I don't know if you know it, about your mobile clinic. Does this mobile clinic need a specific broadband access, and how does it work then?
I think within this mobile clinic, you found a lot of facilities enabled by being linked to the internet and to different systems. So the purpose of this mobile clinic is to bring the clinic closer to the patients. So instead of the patients going to the clinic, this mobile clinic was driving around in rural areas, making stops at predefined places at predefined hours per week, and people could come there instead to take their blood pressure or to do simple examinations that could then be directly transferred to the GPs sitting remotely or the primary healthcare center where those results could be analyzed.
Yeah, I was just wondering of the broadband access, because I've seen that, for example, in rural areas in France, they had some teleconsultation cabins, and when they hadn't any broadband access, they even use satellites, but this is also very costly. So that was my question about. Yeah.
I'm sorry, I'm not sure exactly what, but what technique they were using for this mobile clinic.
Okay, thanks. Adrian, I had a question. If you had some challenges to have every group of population in your project, the elderly and so on, and how did you face it, and how did you solve it?
You mean to treat in a different way to the elderly people or a special population? In this stage, we will approach the population as such, and the main criteria that we are using to include patients is according to the severity of the ADRs. So the first patients will be oncology patients, mental health care patients. I mean, I'm talking about severe mental disorders like psychosis and so on. Transplantation patients, neurology. So first, we are focused on those drugs which are really producing severe damage, because I think this is the main problem. Secondly, we will in another phase, I think we will be focused on different type of populations such as elderly and so on, because in fact it's a majority of patients. For instance, the cardiovascular program, which is part, we have 12 cohorts of patients. One of them is cardiovascular, is mostly applied to elderly patients. I think the main problem here is not to use new technology to practice old medicine. I think we should to reprogram to change the way we are understanding medicine and the use of drugs. This is the main problem. Both doctors, health workers in general, and population.
And you have then enough remote centers for all these patients?
What do you mean with remote?
Well, because we were talking about the access to the specialized centers.
No, what we will have is every doctor here is connected to the healthcare system, to the electronic medical records system. We have just a unique electronic medical record everywhere, even in a remote place or in the university hospital, is working the same system, and you can access to them. And even patients, they have the chance to assess the patient. So this is well established, no matter where the doctor or patients are. And so far, patients and doctor will be able to ask to the program, to the personalized prescription program, what is the better drug combination for them according to their genetics, the drug-drug interaction that they are producing, plus their clinical conditions. This is a question, and I think the revolution is that both patients and doctors can evaluate the treatment in a given moment directly by connecting with the system.
Well, Kathleen has a question for you. What does the population think with respect to the information, the connecting information? Because we often hear the fear of the privacy being lost, or the misuse of the data for unintended purposes and so on.
I guess my feeling, in quite close contacts, I mean, I have not been talking about patients' involvement, but we have a council of patients. Actually, I'm running a course of pharmacogenetics for elderly patients, and it's one of the most amazing experiences that I have been having with the project, because people are not stupid. If you talk to them in the proper words and with the proper time, people understand. And we have 600 elderly people that has been educated on pharmacogenomics, and they understand. So we are running this program because first people need to be informed. I don't like this word educated. I don't know how can you educate. I mean, people need to be informed. If you share information, people may develop an opinion. So that's what we're doing with that. Concerning privacy, data privacy, I know very well this is all concerning Nordic countries, specifically in Sweden. That was actually my working place before, or in the States. But here, I mean, this is a public healthcare system, which is the unique healthcare system for everyone. People, this is not in the worry of people, because somehow it's their own healthcare system. There is a lot of, I don't know. I mean, here there's not private practice high, or there's no competition. So people trust doctors so far. For instance, I'm guiding here a clinical trials unit, and people about informed consent, people trust the system so far. And so far people trust they have a high trust on the healthcare system, and they are not worried on that respect. They are not stupid, but so far they are trusting the doctors, healthcare workers in general. This is a personal opinion, of course.
Yeah, thanks a lot. I had also a question. What were the biggest problems you have been facing?
Here?
Yeah, for the implementation of your project.
Well, the opposite problem that you have in Stanford, for instance. Here you have a low critical mass, and a high level of possibilities. You can do everything because people, for instance, to collect 6,000 patients that we will do in a year with 30 PIs, it has been quite easy, but to recruit people with well training is almost impossible because it's difficult. People don't want to come here. They prefer to go to other place to work, and all the I don't know how to express. We do not have proper supporting system for administration or all the project management. This type of work is done basically by the PI. So this is your work. I have been doing that for 10 years. So the main problem that we have is, one, the lack of well-trained people. Secondly, the lack of supporting system, because there's no tradition in the healthcare system to include research of innovation. It's basically they are providing healthcare, and to assume the research or innovation outside the university or outside the research institution is quite complicated.
Okay, thanks, Adrian. Yes, Kathleen, you have a question?
Yes, thank you. Something else that we have been wondering about, and this is a question to all of you, perhaps. So what we hear now is that the population, in fact, is very open and keen on contributing. There are certain barriers here and there, but how is it to take up innovative new applications in the healthcare system itself by the healthcare professionals themselves? Do you see problems with that? Because it's also the staff that has to take it up and to use those type of applications. So how do you experience this?
Can I just talk? I'll just say that COVID, I think, has been a huge catalyst for what they call that burning platform, isn't it? To become a burning ambition, is that sometimes forced change, people embrace it more. And I know from a health perspective with the National Health Service, the rate at which the adoption of technology has happened throughout, the staff has been fantastic. It's gone quicker in the last 12 months than it has in the previous 12 years. And that, I think, because it was unforced, we had to do distance consultations. And I think it's the same for patients as well, that they've embraced technology as a means to, instead of going to their GP, they use and attend anywhere, and, having consultations online. So I think sometimes enforced change makes people embrace it better, and that's definitely been the case in Wales.
My view about that is the barrier is not technology. The barrier is in people's minds of conception first. People are used to prescribe according to their own wish every day. So they can prescribe any drug according to their own intuition in any given moment. And to change this path that has been going out for 2,000 years, telling them, now you will need to check what are the conditions of the patient. If you fail on that, you may have a problem. So it is to change the way to use drugs, and that is extremely complicated because people don't want to have barriers in their own practice. And for the patients used to think that more drugs are better. If they are new, better. And they are not aware that every drug are causing damage. You can see that now all the problem with the vaccines. Now people are surprised that the vaccines are causing problems. Of course, and paracetamol, even if you don't take the drug, but you are prescribing or acting that you prescribe, you have the nocebo effect. Every therapeutic has a negative consequence. And to change in people's mind that is extremely complicated. So there are two problems. We don't need new technology. We need to change. I'm talking about pharmacotherapy. The way that professionals are using drug, they cannot, for instance, as a psychiatric patient, they cannot receive 10 drugs at a time. This is crazy because nobody knows what will happen on that. And secondly, population need to learn that every drug, any therapeutic intervention is connected with a potential damage. And at the end of the day, it's an evaluation between benefit and risk, and there are no risk. But we are giving this floor of communication just to the drug companies, and I think this is a problem of society. We need to inform people that by taking a drug, they're assuming a risk that they need to be ready to pay. So the negotiation of treatment, I think this is the future of that. We don't need more technology. We need the changing of people and doctors' mind in front of drug treatment. This is my view.
I think it's already changed, and I think that such a program as a stop and start program to prescribe to deprescribing, and I think that some kind of project as choosing wisely can inform the GP and the patient to have less drug prescription, less also examination or test or things like this. And I think that the quaternary prevention is one of the tasks of the GPs in all around Europe, including, of course, rural.
The quaternary prevention I know very well, which is a part of the WHO aims, and I quite well, as you know, all the high-level political design, but in the daily practice on ground, as you are, I assume that you are working as a clinical practitioner, there are few patients that came to say, please, can I take as less drug as I can? I mean, the regular population are still, they assume the idea that all the drugs are good for them, and they don't know how weak is the pharmacovigilance system that we are, not only in Europe, but worldwide. Because we are just taking drug without knowing very well what are the final. So of course we need to go in that way, but we have a long path in that respect. This is my opinion. I'm not negative. I'm realistic about that.
Yes, I agree, but we have to be realistic, and the progress are very important. Years ago, we made a study, and we asked the GPs, why do you prescribe some drugs? The answer was, because I think the patient wants a drug. And when we asked the patient, do you want a drug? No, I was just worrying about my problem, and if I can have no drug, it's better. And I think it's important, and we have to include also, and that's why it's interesting to have the artificial intelligence, to include it in the social prescribing. And I would like to have already the personal assistant as Alexia or other. And it should be interesting to have a champion in Europe that we can work with, or it could be Philips, or I don't know what could be the firm. And we could work closely with them to have a personal assistant for each citizen and each patient. It should be very interesting.
That's what we are building, and we'll start next week. I mean, there is no time in the daily practice to check all conditions that are written for a drug. It's impossible. Nobody can do that. So the technology need to be used in order to facilitate the access to the information. Of course, at the end of the day, two persons in front of a prescriber and a patient need to make a decision. Tools cannot change that, but the access to the information need to be helped by using artificial intelligence, where genetics is just part of this, because there's some other information that is more relevant, like previous history of taking this drug, family, etc., etc.
I agree.
Yeah, me too. I mean, we have a lot to do in the future. Thanks.
Yeah. Okay, thanks. And I had Anna from Wales. Then I had also a question. What is the role of the regional authorities to have an efficient, personalized healthcare system in a remote and rural and sparsely populated region?
I think there's been a lot of mention about, the regional authority. In Wales, there's devolved authority. So the Welsh Government governs the National Health Service, per se, and then about the different health boards that are across Wales. There's also, they've set up in the last couple of years, regional improvement and innovation. So research, improvement and innovation hubs across all areas. So there's 7 of those in Wales now. So the research is definitely prioritised into looking at personalised from an individual perspective, but also from a regional perspective. But they all have to work, well, like with any country, within the national strategies. I think what the big cultural difference has been within Wales is the move to integrate the health and care systems and to involve the sector. And we touched on social prescribing earlier. And what Adrian was saying, there was an initial reluctance, and there is. It's a culture that when individual patients go to the doctors, they feel like they've been shortchanged or disadvantaged if they don't come out with a prescription. It's almost like, aha, I've been prescribed something. And so it is a cultural shift or a mindset shift that has to, the big change is to try and make the individual responsible for their own health care. And that's been the increase. And we're trying to put the emphasis on the prevention agenda as well, as much as anything. But there has been a dependency in individuals. They don't feel right. They feel that something's amiss. They'll go to the doctor and they want that pill to cure it without taking in the full implication, but also without taking in the responsibilities for their own health. So that has been a shift, which is going to take some time. And there is a big role from Public Health Wales, I'd imagine, to change that perception of being dependent on the health service to address your individual health needs, as opposed to taking that responsibility. So, and that's been a big shift forward as well.
Yeah, prevention also will take more and more place. I had a specific question on precision medicine, because there is in Wales the strategy, the genomics for precision medicine strategy. But in the strategy itself, they don't talk about rural regions or or your organizations. And so I was wondering, what's your point of view? Is it possible then to implement it, or?
I think there's a lot of work to be done in that area, and the genomics has only just recently been set up in the last few years, and it is very much focused on the urban areas to date. It is a relatively new concept across Wales, and it's not wide. It is obviously being adopted in specific pockets, but it's not, I wouldn't say it's not widespread as yet. And because it's a relatively new organisation that we are linking in with, but it's only in the last 12 months, and of course with COVID it's all been put a bit on the back burner. But I would imagine that is an area of growth to come across the next 5-10 years. Yeah.
And you hope they will talk to you?
Yes, we link in, we get their newsletters. We invited them to address our conference last year, but unfortunately they didn't. And I think it was like they were getting their feet as well, because, like I said, it's a relatively new organisation in Wales. So, yeah.
Because in the presentation of Jean-Pierre, the lady of Wales talked about it, that the problem was the access to it. It was too long traveling to it. So remote specialized centers were crucial.
Yeah, I mean, it's very urban based. It's based down in Cardiff, and like I said about the tertiary centres, the big hospitals as well. It's all down South Wales, really. There is one up in North Wales, but it's mainly Cardiff and Swansea, which is out to reach for the rural population. So there's a lot of work to be done now.
Yeah, but that's why I asked also the question to the other Anna, because I think some of the obstacles are the same, as the access to it is one of the problems rural areas or remote areas face. And Anna, you said you weren't working on the precision medicine strategies or aspects, but because all the regions you are working on have also a precision medicine strategy, and you don't know if it's coupled or if there is a link to it.
No, I'm not aware of it in my work, so it's obviously not being promoted broadly in the rural areas anyway.
Mm-hmm.
But it's something definitely be interested in learning more about.
Mm-hmm. Yeah, and in the North region, Anna?
Well, there's Bangor up in the north as well, but it's still, I think it's all mainly focused, you see, down in urban, in the cities, in Cardiff and Swansea, down South Wales. It hasn't kind of made, I know you said it's across the whole of the region of Wales, but it's very low profile.
Mm-hmm. Yeah, because all the strategy about genomics, you find it on the internet for Wales and so on. So.
Yeah.
Mm-hmm.
But in practical terms of rollout, it's been quite slow.
Yeah, and we also in the pandemic, and so the priorities have been switching also. So it's not an easy easy phase nowadays. So, but I'm sure the pandemic, on the other hand, was a help for you to have it, all the telehealth solutions implemented in the rural areas. Yeah,
it has been, and I think over the longer term, we'll have a lot of positive outcomes from it.
Mm-hmm. Okay, I don't know if some people of the audience have some question. You still may ask some question or raise your hand or write it in the chat if you have some. A lot have been already said or talked about it, but don't hesitate. We have still a couple of minutes. So as the rural, remote and sparsely populated regions face some specific problems, so we still have some time to discuss it. I was wondering also in Scandinavia, Anna, because they also have all these strategies for precision medicine on genomics and so on, but are you aware of some links or links between what you are doing in the rural areas for personalized healthcare on the digital solutions and so on, and on the other hand with the genomic strategies, or?
No, to be honest, we haven't been looking into the genomic strategies at all in our project. As a research institute in regional development, we switch between quite many topics. And so this in this work we looked more into the practices of using digital solutions in healthcare and social care in regional areas and the rural areas, and to explore what the benefits are and how that can enhance regional development and sustainability in those regions. So in a longer term, those services play an important role. We have this problem of aging populations, of out-migration, etc. And if we can improve the services produced within the healthcare sector, in the social care sector, that would facilitate actually for people to move there and to stay on, to continue living in those rural areas. And I can only echo what Anna said regarding the effects of the COVID crisis here, or pandemic, that it has really accelerated the use of digital solutions. What was found as obstacles and bottlenecks before was suddenly everyone was forced to take those solutions into practice. So things have been moving extremely quickly here, also in the Nordic countries.
Yeah.
I would also like to mention, we were talking about before, the when it comes to the prescription of medicines or the implementation of digital solutions, it has both of those issues have very much to do with practices and with behavior and routinized behavior. And I think this change of mindset, this change of culture, and whether we talk of education or we talk of information, I would also like to prefer the use of information rather than education. But it is very much a change in behavior, a change in routines, to do things differently, not exactly the way we have been doing things before. And that is tricky, and it takes time. and now the COVID situation has helped us in that respect when it comes to implementing digital solutions, that we have been forced to change our behavior in several respects, and we have seen that it is actually okay to do it differently, and it in many cases it's even better than the way it was before.
Yeah, thanks. There is a question in the chat. I don't know who will or who can answer this one. Is there a device standard, an ISO standard, for example, used for selecting remote monitoring devices, like the blood pressure monitoring and so on? I don't know who knows that. Maybe Mikolai? I don't know. Have you faced it, or?
I don't know about a stand, but something that's come up, more and more people are using their smartphones for these kind of, for monitoring blood pressure, and I think they're quite, accepted. They've been trialed and tested against, traditional medical equipment, and I think that's a huge, going to be a growth area in terms of monitoring your own health. The amount of, Fitbits and Garmin watches that are monitoring blood pressure and your pulse constantly, the amount of exercise you do, that's a step in the right direction. But I can't answer specifically the ISO question, sorry, so I'll get off.
Is it also reimbursed then, the use of it?
I don't think so. So I can just jump quickly. So what has been mentioned, I mean, these are rather like well-being devices. So obviously they're not considered as a, let's say, a medical device, because let's say you have some tests, but basically this is, let's say, how should I say, a regular customer product. So I mean, if I have my Apple Watch and basically it measures, I know, my saturation or heart rate. Basically, I'm doing it and I can put it into my, let's say, Apple, whatever health app, and I can show it to my doctor. But this is not, let's say, a standardized, let's say, monitoring system. We have a couple of projects in which, for instance, this heart rate or I know saturation is measured, but normally there are, let's say, two tendencies. So first of all, it's rather an add-on to existing device. So for instance, if you know a diabetes patient under, let's say, outpatient or home-based monitoring, you would just add additional feature to a device, or you will bundle devices under, let's say, one Bluetooth protocol. And the second one, by scaling rather large companies that already have several devices registered, they have more chances to get reimbursed. So for instance, for startups, I mean, they rather tend to start with the well-being devices, and then they move to let's say a medical device registration, as I know, class 1 or 2, depending on the device. But I would say this is quite interesting, but everybody now is trying to build something additional. So not only, let's say, what kind of parameter is measured, but you normally have, I know, a machine learning, deep learning, or AI algorithm behind this that, for instance, makes you to do certain decisions as a patient or customer or citizen. And for this, it's much more difficult because access to data and the regulations around this analytics is not so much mature. So this is the case. But I agree, this is a future. So I mean, more of us will be using this, and it's going to be much more broadly reimbursed than it is now.
May I say something about that? We have a package in the personalized prescription system, which is following the patients in order to detect adverse drug reactions in real life conditions, because we do not have data, specifically in psychiatric patients and concerning one of the major problems that we have now, which is suicide. Suicide, all of you are aware, which is a tremendous problem. Okay, just in order to prevent suicide, probably by following the cell phone, just you don't need a sophisticated tool. It's just following how just by following that's what we have been telling from companies. Just by knowing the activity of the cell phone, they can predict a lot in terms of roughly and about the suicide prevention program. This is we are pretending to do in one of the packages. So what I mean is, of course, to follow coagulations, for instance, or you need sophisticated tools, but there's a lot of simple things that you can do for important clinical matters with a very simple technologies like this.
Okay, I had a question for Anna from Scandinavia, because you talked about the economic incentives. It was in Iceland, if I remember, about the teleconsultation. Was it also because it wasn't reimbursed, or it was only the problem that the GP wasn't paid the same as for real consultation?
Actually, we saw several examples when we talked to healthcare staff and asking what would be the motivation for implementing digital solutions, and what are the hampering factors, and as we talked about before, changing the practices, changing the behavior. You need to in order to do things differently, you need to see the benefits for the patients, or the benefits for the work, that you can do your work with a higher quality, more efficiently, include the patients in a better way, etc. So and as long as the incentives for making those changes are not there, then it is hard, and also usually healthcare personnel and staff and people working in the social sector, they have a large amount of work. They are not sitting on their hands. So when asked to do things differently, there needs to be important incentives to do that, and economic incentives is one part of that, and then I'm not talking about personal economic incentives, but incentives for the department, or for the hospital, or for doing things differently. I hope that was answer to the question.
Yeah, I had also a specific question about the reimbursement of the teleconsultation, but it's really a fruitful discussion, so that's not a problem. But I think we have to close the discussion now. So I would like to thank all the speakers, also the audience, and don't forget, we have also some preventive medicine examples on the Sapphire website that could be interesting. Also that we organize next webinars on the 11th of May and on the 15th of June. And we hope you will also be as many as today. And so I hope also that you have all take some inspiring examples and best practices with you, so that you have a fruitful experience for the future. Thanks a lot, and have a nice afternoon. It's sunny here in Belgium, so I hope at your place also. Thanks a lot. Bye.
Thank you.
Thank
Bye.
you.